Welcome everyone to part 2 of our first QA forum of 2021. My name is Dr. Michael Novick. I am the Director of Education and Associate Director of Quality Assurance for vRad. In this session, we'll be discussing common search pattern misses. Feel free to pause this lecture to review our accreditation statement and the learning objectives for this lecture. Let's dive right into some cases. Our first patient is a 26-year-old woman with abdominal pain and a history of malignancy. These are axial images from a contrast-enhanced CT scan of the abdomen and pelvis. I'm sure you all have personalized search patterns for these cases. Generally speaking, I'll take a look at the lung bases, look for a hiatal hernia, evaluate the heart, and then I'll move on to the solid abdominal viscera, the liver, the gallbladder, the pancreas, the spleen, the adrenal glands, the kidneys. I'll always evaluate the vasculature, the aorta and its major branches, the IVC, the portal venous system. I'll check for lymphadenopathy. Eventually, I will run the bowel. Careful to scrutinize the stomach, the gastric antrum, the small bowel, the colon. I'll always try to identify the appendix in the right lower quadrant and comment on that in my report. And when I get to the pelvis, I'll review the urinary bladder, the reproductive organs, and of course the abdominal wall. Here's a little fat-containing umbilical hernia to comment on. And finally, I will put the bone windows on to evaluate the osseous structures. I generally have a better time doing that in the coronal and sagittal reformats, but I'll always take a look at it on the axial images as well. In every body case, I will put the lung windows on to evaluate the lung bases for any pathology. You can also use this to scrutinize free air in the abdomen. Had I used my normal search pattern in this case, I would have gone through the solid abdominal viscera, the bowel, the vasculature, the pelvis, the abdominal wall, the osseous structures, and eventually the lung bases and lung windows. I would have missed a major finding in this case. There are subtle but real filling defects in branches of the right lower lobe pulmonary artery, which are visible at the lung bases in the soft tissue windows. If you modify your search pattern to take a few seconds to evaluate the pulmonary arteries at the lung bases on every CT scan of the abdomen and pelvis, it only takes seconds and you will never miss this finding, which can present with upper abdominal pain. Here are the axial images from a follow-up CT angiogram of the chest, which much more clearly delineate the findings in the right lower lobe. Our next patient is a 33-year-old man, status post-assault. These are axial images from a non-contrast CT scan of the chest. I would encourage all of you, as we're scrolling through here, to use your own search pattern. We'll skip the lungs and the osseous structures in this case just to focus on the important finding. Of course, you'll want to look at the solid abdominal viscera and the bowel and whatever vasculature is visible in the upper abdomen in these cases. And we all, of course, use the bone windows to evaluate the osseous structures. Search pattern misses are typically not eye tests. They are usually obvious findings that we miss because we have not included something in our search pattern. In this case, there is a displaced fracture of the costal cartilage with overriding of the fracture fragments. I'm sure this is a finding that all of us would see, provided we include this area in our search pattern. As radiologists, we should always be evaluating and reevaluating our search patterns to address any deficiencies, and I think it's important to try to view misses as an opportunity to improve going forward. Our next patient is a 71-year-old man, status post head trauma. These are axial images from a non-contrast CT scan of the head, and as I go through my search pattern, I will note senescent changes, vascular calcifications, all the things I would expect in a 71-year-old patient, but of course I'm going to be drawn to the right periorbital soft tissue injury. Here are the sagittal images from the same patient, and again, my eye is drawn to that right orbit. I want to be careful never to abandon my search pattern when I see an important finding that bears more scrutiny. Of course, if I omit something from my search pattern, there is almost nothing I can do to avoid a miss other than relying on luck. In this case, I'll draw your attention to the right globe. The periorbital soft tissue swelling was obvious to all of us, even on the first pass. The dislocated lens, however, while obvious in retrospect, is something that could easily be missed if we don't scrutinize the globes themselves. Here again on the sagittal images, we see pronounced periorbital soft tissue swelling. And the dislocated lens in the dependent portion of the globe. In this case, I suspect most of us would have made this finding because our attention was drawn to this area by the overlying soft tissue findings. However, in many cases, we're not so lucky. For example, retinal detachments are a common finding on head CTs, and we frequently don't have secondary findings to draw our attention to the globes in those cases. So I would urge all of you to include the globes in your search pattern on all head CTs. Our next patient is a 74-year-old man who fell off the toilet. These are axial images from a CT scan of the cervical spine with the bone windows on. And again, everybody has their own search pattern. For these cases, I'm sure most of you are looking for fractures first and foremost. I tend to start with the sagittal bone windows to look for malalignment, the normal cervical lordosis, the facet joints, the dens, but everybody has their own system. I'm sure many of you already do this, but if you don't, it's hugely important to have a look at the lung apices on the lung windows for reasons which are almost certainly already apparent to you. I always use the coronals and sagittals in the lung windows to look for pneumothoraces on CT scans of the cervical spine, because sometimes they're apparent on these reformats and not on the axial images. The findings should be readily apparent on this single image from the coronal series. There is a tiny right apical pneumothorax. Here are the corresponding axial images from a CT scan of the chest that was performed concurrently. And I wanted to demonstrate that the pneumothorax we saw on the C-spine images is virtually invisible on this study, which brings me to a very important point. If you're reviewing the CT scan of a chest in a trauma case, always review the C-spine images for tiny apical pneumothoraces, which can be missed on the chest images. Also, if you're reading the CT scan of the cervical spine and you see a pneumothorax, it's really a good idea to reach out to the radiologist who is reading the CT scan of the chest to alert them to the findings, because they may not be able to see them on the CT scan of the chest. Our next patient is a 7-month-old boy who fell off his bed. Here are the axial images from a CT scan of the face with the bone windows on. Of course, we're going to scrutinize all of the osseous structures, the paranasal sinuses, the orbital walls, the maxillary sinuses. Always a good idea on these cases to look for soft tissue swelling because it may alert you to the site of injury and a potential underlying fracture or other abnormality. Here are the soft tissue windows from the same study. Again, we're looking for soft tissue swelling or lacerations. Always evaluate the globes, as we discussed earlier. It's not ideal to be evaluating the brain parenchyma on CT scans of the facial bones and cervical spine, but sometimes the head CT is not performed, and this is the best we have. So it's really important to always take a look, include in your search pattern the brain parenchyma when you have these scans to evaluate. In this case, there are subtle but clearly visible subdural blood products overlying the bilateral convexities. In this case, it is a bit of an eye test, but if you do include the brain parenchyma in your search pattern in these cases, you at least have a fighting chance of making this critical finding. Here are the axial images from a follow-up CT scan of the head performed sometime later. The collections are now predominantly hypodense, having evolved since the prior study, although you can appreciate a little bit of acute blood dependently. And now there is also some ill-defined hypoattenuation in the left parieto-occipital region. Very important to make these findings prospectively. Our next patient is a 67-year-old woman, status post-trauma. These are the axial images from a CT scan of the head, and as we scroll through, I'm sure you'll appreciate the senescent changes that are typical for this age group, volume loss and microvascular disease. Of course, this is a trauma case, so we're looking for acute blood products, soft tissue swelling, fractures. Here are the coronal images from the same study. Very important to review the reformatted images in trauma cases. There are frequently findings that are missed on the axial images that are much easier to pick up on the coronal and sagittal reformats. So if you don't have those, always make sure to request them from the source images. In this case, the pertinent finding is visible on the axial images, but really only on one image. So it's very easy to miss this as you're scrolling through. These are acute subdural blood products layering over the tentorium on the left. This is a common place to see subdural blood products and one of the most frequently missed locations. The finding is subtle even on the coronal reformats, but you can see the asymmetry on this image much more clearly. I think the sagittal images in this case were particularly useful. Again, we see trace blood products layering over the tentorium. So this is an acute subdural hematoma, very easy to miss in this location as you can see, but if you include it in your search pattern and utilize the sagittal and coronal reformatted images, you are much less likely to do so. This is a similar finding in a different patient just to show you how easy it is to scroll through this when you're evaluating the images. Again, it's easier to see the asymmetry on the coronal reformatted images, but this is by no means an obvious finding. Our next patient is a 64-year-old man with altered mental status. Here are the axial images from a CT scan of the head. And again, we see some senescent changes. We're obviously looking for signs of acute ischemia, perhaps mass effect, sulcal effacement, midline shift. The coronal images from the same patient who is a little bit tilted in the gantry. Here is the pertinent image from the axial series, which demonstrates hyperattenuation in the region of the right M1 segment. This is the classic dense MCA sign consistent with acute thrombus. In all likelihood, most of us would make this finding because it's not terribly subtle, even if we don't include this region in our search pattern. However, if you do include it in your search pattern, you will never miss this finding. Here is another patient with the same finding, and I'm sure you can appreciate how easy it would be to scroll through this if you're not looking for it, especially when the findings are even more subtle than they are here. If you're so inclined, this is an interesting article on interpretive error in radiology, and I thank you for your time and attention. See you next time.